Okay, so hello everyone. I hope you all are doing great and keeping safe and doing amazing this tonight. Okay, so welcome everyone to one of the largest platforms that is Dentistchannel Online, and we would welcome you all to the Implant Expo today. And today I'm going to be your host, that is Dr. Isha here, and we have the most amazing and the most dynamic speaker with us today. That is Dr. Shoukath Ali, and he's there with us. First of all, a very warm welcome to Dr. Shoukath from
Thank you very
Dentist
much.
Channel Online team. And we welcome you here with us. So he has one of the most dynamic speakers with us. He's been very instant and very graceful with his webinars. So just starting with a little bit of his introduction, that Dr. Shoukath is currently, he's one of the few implantologists who has dental implantology privilege license in both Dubai Health Authority as well as Ministry of Health, Sharjah, and currently he's practicing in Dubai, and he has done his master's from Austria. If I conclude, without much elaboration, he was one of very few keynote speakers who has given one slot of lecture after finishing. That he was invited again for the second one in our last year World Dental Implant Expo one, considering on the public demand. So he has always been on the public demand, and I think you all will love him today on this on our platform. So welcome, Dr. Shoukath Ali. How are you doing today?
Thank you very much. It's great. Very nice presentation. Nice introduction.
I tried my best.
Okay, so we'll.
Yes, so we can. I'll hand it over to you, and we can certainly start with the webinar now.
Okay.
Okay. Very sorry to interrupt in between, but to all the participants, if you have any questions in between, just drop those questions in Q&A sessions, and your questions will be answered by Dr. Shoukath by the end of the webinar. That's all. Thank you. Please carry on.
Now everything is clear, visible?
Yes, it is. We can see your PPT.
Okay, thank you very much.
Yeah.
So here it's starting of the night, and in Canada it's in the morning, right? You just got up, it's 10 early morning in the 10.
Correct.
Here, this is evening time, and as all of you know, the desert is spread all over Middle East. And I'm coming from India, the southern part, Kerala. So there is everywhere, wherever you look, you see greenery, same way as you see sands here. So this is a night view, and it's going to be a little cold by end of this month and next month. So evening time, most of us used to go to the desert. And this is a scene we see in the desert, a lot of stars in the sky. And this is something dangerous. If somebody is in the desert and they don't know the location, how to go, they don't have anything to navigate. They have only the stars in front of them. And that is the only guidance they have to take. That was the situation among Arabs in the early stages. If you look at the history, they have no other way other than finding out a way to escape from deserts. So they have found out, they have created astrolabe. And using this astrolabe, they could locate the star and they can get the direction whenever they lost in the desert. And from that stage of knowledge, that knowledge seeking habit, it has opened a vast area of astronomy. They started learning more and more about the stars. And at present, we have a lot of equipments which was not available in their time. So we have every stars, every galaxy, and the universe, multiverse, everything in three-dimensional concept at present in front of us. Meanwhile, one side, this was going behind the astrolabe. In China, people were, you can see the most primitive model of compass. So everywhere, all over the world, people try to use something to get a direction for the navigation. Somebody use astrolabe, someone else use compass. Then people started sharing the knowledge and using everything. Now we are in modern era. So we have whatever we want, all the data in our mobile phone, the GPS form. It's not stopping there. We have everything in our car, and that's how the Tesla has come into the market. Here, Tesla don't need a driver. It can drive by himself or itself, and it can navigate without going wrong directions, reach into the right place with a proper navigation tool. So that is the age we are at present. So we have to come back to the history of the implantology. We were going through so many phases. We were navigating through the unknown areas. And now we have reached in a most sophisticated, most knowledgeable area of the implantology, the science. So we will be discussing about the tools, tips, and tricks of the modern age implantology today. From the counting 10, I'll be reaching to the 1, and it will be finishing very fast. This is the Yomi, the robot. And Yomi robot is the implant helping robot. It's actually not a replacement of an implantologist. It's a symbiotic relationship between the implantologist and the helping robot. I put it in the 10th place because it's a very, very important, very advanced and modern technology, and which help implantologists to take the operating hand into the patient's mouth. Once it's in patient's mouth, the doctor will be releasing the hand from the handpiece. So the robot, it will be locating, it will be positioning the angulation, it will be placing the drill into the correct angulation, correct place in a proper judgment, after proper judgment ways. You can see one big screen. This is a guidance for the doctor, and the second screen is a input of Cbct. And when the patient move, there is an arm. This will be giving information about the patient's movement, and it will be adjusting the robotic arm. And that is the Tesla of implantology. So from here, the navigation system has reached into the Tesla. And from here, we have reached into the Yomi, the robot. Both are not at present there in my life, my practice. But one day, one fine morning, we hope all of us will be having the luxury of both Yomi and Tesla. Then coming back to the olden history again, here the 9th position, I have placed one of the most reputed implant in this world, which is having a track record of 35 years. That is Biocone. We all know, or some of us know, Biocone is being there quite long time. And all the clinical cases, whatever I am showing here is from my practice. So you have to excuse me for the photographs if it is not of good quality. Here, the first page itself, I have placed the literature details about the Biocone implant. Because if you search Google Scholar, this is one of the most discussing implant in this world because of the time period it is being there in the market, because of the more and more R and research and development, R&D part they have spent on this implant. Here you can see this is a 6.2 height, long, tall man with good musculature, with heavy biting force chances. You can see the strong mandible. Some of the time, people are or doctors are discussing about the small, short Biocone implant as if there is no bone, then go for Biocone. So if there is bone, you can choose the other implant. This is not that way. That is the reason I have placed this specific case in front of you. Here we have enough bone. The patient is having strong biting force, very heavy musculature, and I have done 3 implants, 3 short implants, each of them 6 millimeter height. You can see purposely I have kept one cantilever here because this second premolar is going to get extracted. So once it is extracted, then one more implant will come here, then this will be the superficial portion of the bridge will be changing. Forget that part. Look at the implant junction to the abutment. You can see a lot of bone formation in that area. So if you can place a small implant, a short implant, which can take all the load, which do not create any problem, then you don't have to drill a big hole and make a big implant. That's the concept of Biocone. You can see the soft tissue, this 3 implant and soft tissue around is beautifully, it is there, and this case is done quite long time back and still follow-up is going on. It's perfect, and that's why I have put this picture here. So why this Biocone short implant is different from other implants? I'm not going deep into the topic. One of the main differences, this is not having a screw to hold the abutment part. It's a 2-piece implant. At the same time, the small abutment portion will be sliding into the implant, as you have seen in this photograph, and it will be having a friction lock, so 0 micro leakage or 0 micro space in between abutment and the implant. So it will be cold welded, and because of that property, you can keep it deep inside the bone. So all the Biocone implants are meant to be kept subcrustal. You can see this lady. She is diabetic and on insulin. She has always carry the this acute check to check the blood sugar level. And today morning, she is 43. Today means the day of the surgery. So we have given some juice and all. After that, we have started the surgery. Here you can see I have placed very small implant. And these 5 mm implants purposely used because she don't want a sinus lift, or I don't want to make a sinus lift in this case. So implant is kept subcrustal. You can see here, and some bone augmentation is done, bone graft is placed. Then this is the healing phase, secondary stage. And after loading with the implant, it's being quite long time, and you can see the bone level is maintained at the level of this abutment. Here you can see some radiolucency, but these will be improving over a period of time. Again, this is a case done a few years ago. So by every time when the patient bite, that area will get stimulated and there will be good quality bone formation. So this bone will be holding the entire implant in place. And the lucky part is this special design of the Biocone implant, the bone around the implant seen is not the way the bone seen around other implants. You can see that area will be almost like a cortical bone. The reason is Biocone implants are placing into the socket frictionless. You have seen the first slide. I have placed the implant with my hand. So it is just with the finger pressure, the over-prepared osteotomy, we are just pushing it into the place. So that area, new bleeding will be there, and that bleeding will be converted into a good quality bone all around this implant. So even though it's a small implant, it's subcrustal, it's going to serve the purpose. This is an extreme case, another case. You can see the first slide is not from the same case. This is just placed to show the Biocone drill. So here again, 5 into 5 mm implant. This is placed in the first molar area subcrustally, and you can see the bone grow all around this implant and all around this abutment. And this is a day of restoration, and this is after 2 years follow-up. You can see still you cannot make out the difference of the soft tissue or the gum area from here to the natural tooth. So if you can hold the bone, if you can hold the soft tissue, then why I have to drill all the way down and make a very big implant inside? That's a question from Biocone. So there are some reasons. That's why I am not only practicing Biocone. I have the other systems also. I'm not promoting any products, but at the same time, I'll be definitely informing and sharing my knowledge about the product which I am using. I'm happy with that. So that's about the Biocone. So Biocone was actually, it had a design, it has developed a science that was lasting 35 years. Whereas when we look at the other implant systems, they are keep on changing their shapes and the science, the technology, because the technology was outdating after some time. So either you have to run along with the time, update with the technology, or you should be updated in the first place when you start itself. So that is why Biocone is still in the market and worldwide very popular, and those who are using Biocone usually will never go away from Biocone, even though they have other implant systems in their practice. So that ends the 9th position. Now the 8th position is something we are very familiar, platform switching. Actually, the platform switching concept came into the science in 1991. At the same time, in 1985, Biocone is already a platform switched implant. So there is no harm in taking good things from one and using the other place. So here we know the implant diameter and the abutment diameter are different. So when the abutment diameter is small, the implant abutment junction is actually shifted away from the bone. That's the idea behind this platform switching. So you can see Noble Biocare two types implants here. One is without switching, one is with switching. So these indications are different. Both are right, indications are different, but most commonly now the science is going towards platform switching, and the companies which were not using platform switching, they already switched platform, even though it's not taking the same name like from others, maybe shifted platform or something like that. Some other deviations will be there, but the concept is same. Here you can see the implant, that abutment junction is clearly away from the bone. So if there is any micro leakage in that area, there will not be any bone loss. This is a case. It was an immediate extraction, a lady patient, and did implant and did some bone graft, single stage surgery. You can see the abutment size and the implant size. Implant size is 5.7 diameter, and the abutment is very clearly switching inwards. So the junction is completely shifted away from all the 360-degree away from the bone. So the biological width will be maintained, and the healthy, soft and hard tissue will be in right place. So that was about the platform switching. That's a beautiful concept, definitely. And it is kept along with the Biocone implant. And these are the new things we have been learning from the past history of the implantology. So when we are learning, when we have got this knowledge, using that knowledge, we have to update our practice. Otherwise, if we are not ready to change, we will be definitely changed. And this is one of the most important change happened in the world of implantology. And when all the implant companies, when they were concentrating on the implant side, this is Dr. Sala, a periodontist. He and his group, they were looking at the bone side, the patient side, what improvement we can do in that area. That's how the Versha, Densa, this Burke concept came into the picture. So now those who are using the Versha, these Densa burrs, they are actually shifting from our conventional implant protocols into this new technology. Here, the osteodensification, you will get a lot of articles in literature supporting this and articles in literature which is talking against that. But looking at our practice, what we are getting out of this. So my point is only concentrating on that. Here you can see this case, I have done a lateral sinus lift. You can see the area is prepared beautifully and the bone is shifted inwards, and I could do proper grafting and everything is done beautifully, fantastic. The problem is my job is done beautifully, but the next day onwards, another few days, the patient is having a lot of swelling, a lot of discomfort, a lot of difficulties. So when Versha came into the picture, this Densa burst, it has a capability of densifying the available bone to methods of cuttings are there. One is a forward cutting, clockwise cutting. It will cut the bone. And when it is reverse cutting, it will condense the bone. So here you can see the tooth is extracted and the interradicular bone, I was expanding that bone, which I can do with any other tools in my hand. But the difference there and here is, here you can see the condensed bone available all around this, the implant area. This is the area I'm going to do implant. That area is almost like a cortical bone. It's a good quality bone. And along with that, sinus membrane is lifted. This photograph is not showing that. The next one, this is another case actually. This one is showing a beautiful Schneiderian membrane. You can see when I use this denser burrs, I have been lifting the sinus same way like our crustal approach, but more predictable way. And in this bone, I could place implant at the same time. You can see this is Schneiderian membrane and we don't have much bone there. Then other bone graft, lateral augmentation I can do. That's a different thing. But lifting and placing at the same time in this bone, which is almost near to impossible if it was using by some other methods. That's why the Bursa densa osteodensification came into this series. Now the sixth position is something sixth sense. That's a Cbcd. Here, one easy method for informing, educating patient about the treatment plan is using the Cbcd. We can show them how their face is without the flesh. So this, you can relate these two images, and this is after the treatment. All on 4 upper implants are placed. This case was there in the discussion. This is my last week patient among Dubai dentists. The question I was asking them, I have the OPG in front of me. This is the area I'm supposed to place the implant. I have one IOPR taken here and a clinical photograph. So when I palpate in that area, there is a good quality, good quantity bone I could felt. No pain, nothing. But here we can see the Cbct image. There is a very big area of something unknown. We call it air pocket. Air pocket, the concept was coming from, again, the Biocone implant. Usually Biocone implant, after drilling, we press with the finger or maybe we tap into the place. So if there is any air pocket, when we tap into that place, it will suddenly fall into the place. And it will be a complication about the Biocone implant if we are doing that one, because there is no drilling and placing. It is just pressing or tapping. So that's the reason they are more discussing about these air pockets. It can be some kind of cyst, some pseudo cyst. This is not a cyst because there was no lining. There was no any leaking fluid. You can see when reflecting the area, it's showing only a small hole. The Cbct is showing a full big picture, and you will see in the next slide, this is going all 13 millimeter down till very deep into this area. So the management was different thing. Just shown you this one because to inform the importance of Cbct, because Cbct is no more considered as a luxury in implantology. It's a very mandatory thing, and we all slowly should have a plan, if those who are not having a Cbct, to incorporate Cbct into our practice. Then only we'll be running along with the time. Now, in the fifth position, this is a science, the socket shield technique. Actually, this was our situation before. We are confused. There is something precious, some precious bone is there, and we don't know how to keep it there. When we remove the tooth, it will go. That thin paper-like bone, we have to keep it in place to keep the gum in place and to get proper aesthetics. So somebody has come out. When we remove the tooth, the bone is losing. So why don't we keep that portion which is protecting the bone in place and remove the remaining tooth and place the implant? Again, that was a eureka of the implantology. And here you can see this patient two laterals are removed and socket shield technique is done. And two Straumann implants are placed. You can see this was the day of final restoration. You can see the little gum. I have to cut little gum in order to get the proper shape. I was not worrying about the gum recession. Gum was excess and surplus for me to cut and trim. So that is about socket shield. I'm going little faster now. Here we are at 4th place, and there is something interesting. We were talking about the olden methods, and we look at the place, we measure the site, and we do implant. We do bone tapping, we do some kind of palpation, and we find out what type of bone it is, how good it is, and how much we have place to keep the implant. And when coming to the Cbct, everything is in our mind. We have to do some guesswork. So when I read a Cbct, then I need some kind of guide. So first, when the patient comes, usually what I used to do, I used to take the impression with some kind of markers in that, then only take the Cbct. Then looking at the markers and looking at the site, I can do some calculation. So here, this is the new age implantology. So why don't we have something in the Cbct, in virtual world, which is measurable and which is identical to our analog and which is in the hand? So from that concept, this DD has come out, and I'm very happy to present it in 4th place. The reason is I'm one of the person who is getting, I'm actually getting most of the benefits out of this invention by Dr. Suhail Hussaini. And here you can see I'm with him. And this guitar-like thing in hand is a prototype of this DD. This is a diagnostic index, dental implant diagnostic index. That is why DIDI. So if you type diagnostickey.com, diagnostickey.com, you will be directed into that web page. And from that, you'll be getting all the instructions how you can download this one and keep in your computer. Even though you don't have this thing, when you have the digital part, when you can download it and keep it in your PC, when you read any Cbct, you can use it and place it in that Cbct, and you know how much is in this area, how much is in that area without any errors. And when you get that piece in hand, if you have the patient in front of you, you don't even have to make a model, just keep it in the mouth, just check in the Cbct. So both places will be getting the accurate measurement. The next good, beautiful thing is you can use it in patient's mouth and directly drill, because There are some drilling areas also in place. So this is Dr. Suhail Hussaini, and he has given into the world of implantology, and definitely this is a patented one from Canada. Definitely this will be there in every implantologist practice, I am sure, because that's a future. There is a future in this. And there are so many things in each of these diagnostic key, and we have to sit and learn how to use that one. Not very difficult, but there's a small learning curve. Once when we know that, we can use it. You can see this picture. It is digital one in the Cbct, and same the analog one we have in our hand, and we can place in patient's mouth. So everything will be getting into the finest details without any room for error. Now coming to the more important things, that's in third place. We all were discussing about osseointegration for some time. Then we all discussing about the keeping bone in place, so the soft tissue will be in place. Now, this is the era of aesthetic implantology, and we will be a big failure if we cannot keep that aesthetic up to the patient's imagination. And you know, every patient have their own way of imagining the concept of beauty when they are going for getting it. So there is no room for error, and we have to think about this muco integration. And this is coming from Noble Biocare. And the design of the implant in Noble Biocare, you can see the roughness on the surface is different for bone and different for soft tissue. That is a sense, and this yellowish area is just because of the anodize. They use this technology to make it more soft tissue friendly. And here you can see two parts. The implant and the abutment will be fixing onto the implant, and that portion of abutment we will never be removing. That is a one-time abutment. So whatever we are doing in prosthetic part will be coming above that. So it's almost like a platform, almost like a external hex. But we know there are so many issues with the external hex. And so this will be solving the issues of external hex as well as getting the benefit of that area, and the soft tissue will be maintained without any issues in right place. Here, when we look at the case, this is my case. When we look at the case, if it's an implant case, first we will be started looking at the interdental papilla. That is the area we are getting most challenges. Then we will be getting we'll be looking into some other details. Because if there is a black triangle, whatever we do, the solution is, we know, it's very, very limited. Here, because you all are experienced expert implantologists, might have guessed which tooth is my implant. I have kept this slide purposefully because this is the most challenging tooth in implant dentistry, all of us know. And the papilla is here. That was the canine. Papilla is here, and soft tissue is there without any issues, because just with the science, took the science part, took the technology advanced technology part, and blend together, and we can deliver a good result to our patients. So coming to the second stage, this is the implant stability quotient. Most of the time, implantologists, especially those who are starting in the starting stage, will be starting with very, very minimal equipments. This one I have kept in the second place because this is really, really important. This case, you can see the date, it was 2012. This was the type of ISQ machine that time available. Now, a lot of differences. Here you can see I'm checking this, keeping it in this position. Now, the newer one, you can see it should be in 45-degree angulation. A lot of changes are there. A lot of advanced things are there. And incorporate this one into the implantology. That's a good thing about more predictable treatment. And coming to the number 1, this must be most interesting because this is number 1. But this is not like that. I have kept it as number 1. You can see these clocks do not have any handles. People don't have time. They have come to get the implant done, restoration done yesterday, not today. So how can I tell him I have to remove it, I have to keep it for this many weeks, this many months, this many years, then only I can give you a tooth and send you back home. Now the implantology, the entire implantology concept is changing. It is considered now as only apical extension of a crown, not the other way. So they are coming not for that apical extension. They want to have the tooth which is visible. So there came the most advanced thing, same-day dental implantology. So all of you know same-day dental implantology is coming into the market and it's making big time money. So why don't we go to same-hour implantology? That is the most advanced thing when I'm thinking about myself. Here, the protocol I'll be just briefly explaining. The patient will be coming to the clinic and they'll be doing 3-shape scanning. And before I see the patient, scanning is done, then Cbct, other things are done. Then when I see the patient, already everything is measured. I have DD in my hand. This is DD. And this is that diagnostic key. I don't know whether it is visible anyway. So I have this one in my hand and there are measurable areas in this, just kept in patient's mouth. Place the implant because already angulation is decided. If I have time for the surgical guide, I can make it. Otherwise, I can use this one. Place, drill, and place the implant. Once the implant is done, I have the digital analog impression post kept in mouth, do the next scanning. So my scan is ready and with the digital, everything is ready. Abutment selection I have already made. Next thing is, I need something to print the crown. So there are different types of readily printable things and we can add some stain, especially if it is in posterior area. We can add some stain. If it is in anterior area, we can give it again with the customized staining. We can do it and keep it in place. We can use it as temporary. If it is in posterior area, we can make it as permanent. Then the question will be there, what about the gingiva? Now we know the technologies to keep the gingiva in place. Not in first case, not in second case. Once when we are started doing these, following these protocols, we'll be able to keep the gum because we are keeping the bone. So we know it is almost predictable. I don't say it is 100%. So if it is almost predictable, that predictable crown I can give at the same day of implant placement. So everything is going to finish in first day in 1 hour. That is the most important advanced implantology. And if few years ago, we didn't have an app to navigate, to go to unknown places, because we didn't have a mobile, with all these smart technologies. Now we have everything in our hand. So in future, this also will be there in every dental clinic. I hope so. And for that, we have to do some homework. We have to do some research. We have to go behind the science till we reach into that point, because you are a genius. And I'm giving my Diwali seeds to all. Thank you for watching this, and we'll come to our question answer sessions and wind up this. Thank you once again, Dentistchannel Online team, and the people, those who watch this one in this live session as well as later.
Perfect. What an amazing and a very informative webinar by Dr. Shoukath. Thank you so much, Doctor. And it was very informative for me as well. Trust me, I was just glued to my laptop and I was listening to every single word. And loved your presentation with simple language and simple terms, which, I think even a fresh intern could, even also understand that. Okay, so before I jump into Q&A session, I would love to share one presentation. And please allow me, guys, to share the screen with you all. Just a moment. Yes, Dr. Shoukath, can you stop sharing so that I can just share the presentation?
Okay.
Perfect.
Okay now?
Yeah, perfect.
Okay.
Okay, so to all the participants, today I will be talking about Dentistchannel Online and World Implant Expo 2021. So Dentistchannel Online presents World Implant Expo 2021. And what is Dentistchannel Online? We are India's largest digital dental media company. And our motto is to support dentists and support dentals as a profession. Along with that, we conduct a lot of webinars, a lot of workshops. So webinars are always very informative, and with one of the best doctors and dentists all over India and outside India as well. We collaborate with them. We have all these interesting topics which come up, all the latest topics, and we have webinars with them. Along with that, which is we also have workshops. So workshops generally are of 1 day or 2 days, which are more interactive, and you can learn more and better and in depth about a topic. Okay, now moving on to World Implant Expo 2021. These our Implant Expo started yesterday, and these are a few of our keynote speakers. Now about us. So Dentistchannel Online Pvt Limited is a leading dental media company that aims to spread awareness and knowledge regarding various aspects of dentistry. We conduct regular webinars and courses, as I said, on different areas of dentistry. Being a prime member of Dentistchannel Online brings you with several opportunities, and which includes the CPD points and accredited webinars and dental courses. Okay, now be a Prime member with Dentist Channel Online. Okay, so why you should be a Prime member with Dentist Channel Online? Because once you're a Prime member with us, you will get access to the amazing webinars, the workshops, and there you will find some discounts and some on special offers on the workshop prices. Along with that, you will be given a certificate. So if you're not a Prime member with us, you will not be awarded with a certificate for any workshop or any for any webinar you attend with us, and also the Implant Expo is also included in that. So this is a demo of the certificate of participation with us during this Implant Expo 2021, in which we are the certificate contains 30 CPT points accredited by State Dental Association of Rhineland-Palatinate, Germany. So make sure that you are a Prime member with us so that you get awarded by this amazing certificate of participation, which can also add to the CPT points. CPT points as well. Okay. Now, moving on, these are the few more we have. Webinars are coming up with us on our platform, and you can get the detailed schedule on our website, on Dentist Channel Online website. Okay, now for the latest updates, for all of you who are participants, one of the participants who are new to our platform, just send us your full name on this number, and you will be getting all the dental updates of the webinars, workshops, anything which is coming up with us, so that you are completely involved with Dentist Channel Online and you are updated to the latest news as well. Okay, now moving on to our sponsors with Implant Expo, that's Monoplant, Biocone, Qualia, Simple Dent, and various others, as you can see on the screen. Okay, now for more recorded videos and more information, do follow us on Facebook, Instagram, and YouTube. Instagram, our page name is Dentist Channel Online, and you will find us right there. And you have any query, you can DM us there, and just follow us to get your daily dose of some updated dental news, webinars, and workshops. Now we would be going to the promo videos. Okay, I think short implants are one of the most interesting, I think, implant topics I've heard. As Dr. Shoukath, you mentioned that patient comes in for that crown, right? And that the implant is actually a apical extension of the crown. And I really found that sentence very interesting. So would you like to explain a little bit about that?
It's a new aesthetic implantology concept, because olden days we were talking more and more about big surgeries. Only 3 specialists used to take the case. One is oral surgeon, one is a periodontist, third one is a restorative prosthodontist. But these implant companies, they were getting only very few cases for a long time, because only it was confined to these 3 specialties. Then they started educating these GP doctors. GP doctors started doing a lot more implants than any other specialist. Then there started coming up issues like the crown root proportion issue was there, the aesthetic issue was there. So all this started coming, considering as a failures. it's categorized under aesthetic failures.
Okay.
Then they started looking into the solutions. So there came again bone grafting and other issues to solve this one. So it was again going back to the specialist. But at the same time, now whatever is going back to the specialist is only a particular percentage. Around 70 to 80% of the cases can be handled by GP doctors. And these GP doctors, and when they do it, this part should be there in mind, because once the implant is placed, it's saying is there, like same like a marriage. If it fail, end up in court, either marriage or the implant. So that's the issue. Once implant is done, then the bond is there. So that long-term issue has to be kept in mind when we do the implant. So most of the failures are aesthetic failures. That is why now it is coming more concentration into the aesthetic implantology. So that is why the crown part is given more important. Forget about the crown part. Now the temporary part, when we do the anterior case, if there is any difference in the shade in the temporary, patient will not be leaving the clinic.
Correct. Very correct. Yeah. Yeah. Okay. Perfect. Now let's jump to the question answers by our participants. The first question is how to manage the golden rule with DIDA.
DIDA. I don't know which golden rule they have kept in mind. If it is about the implant positioning or about the aesthetics, one of the most simple thing about DIDA is when we have something measurable and digitally as well as analog. When we have something in our hand, if there is no digital part, if something is there in our hand, and if we see the space, we know every time when the people do the surgery, after the surgery, when they take a radiograph, they will be thinking if that 1/4 millimeter bit there, or if that 1/4 millimeter here, it would have been little more better. So sometimes we see very wrong angulated implants. So all these things up to a certain extent can be solved by using this guide. Actually, no, this Strawman has come up with that special hands. So for every diameter implant, we can place it to that area and we can see. Once when I do implant, this is the area my implant is going to occupy. And in the middle, there is a hole. We can use it as a pilot drill. Same thing is there in this also. But again, this same handle we can use in the restorative phase. That's the most interesting thing, because there is something to cut the soft tissue on one tail of this one. That's scorpion-like thing, and the tail, there is something to cut the soft tissue. You cannot go wrong if you use it in the right place in the first place. You cannot go wrong when you do it in second time, because that is the only place you can cut. If it is a full flap reflection, if it is half flap reflection, everything is incorporated there. Because Dr. Suhail Hussaini, I know him, he's being, in my knowledge, he's being there more than 20 years, but not 20 years, more than that he is there. But from 20 years, I know him there. And all this, he's always thinking about the next step in implantology, and everything is incorporated into that small piece, this small piece of DD. So we can do more predictable way. Maybe if that is the point they mean by golden rule, I think this is one of the simple way. If something else, please come up with the next line of the question. I will clarify that.
Okay, so another question is by Arundhati again. Sir, can we get the reduction in the bone from where we will place Biocone?
Biocone, if somebody is doing it right way, you will not lose bone. Instead, you will gain bone at the crucial area. When I mean it right way, there is a learning curve. Definitely for everything there is. And Biocone also there is. So once if you started learning how to use that method, then you will be amazing to see, you will be wondering to see every radiograph you are taking after 1 year, 2 year, 3 year, will be getting some good quality bone above the implant.
Okay, amazing. Now, Dr. Yash Kumar wants to know how to decide immediate loading implant. Like, how do you select the case in that scenario?
Immediate loading. Now we have all these tools in our hand. Cbct, even though there are some difference of opinion in that Hounsfield calculation, but still we know it's not absolutely showing wrong. We know 150 to 350 and 350 to 850 and more than that 1250. We know the types of bone is having some relation to that one. So that calculation we can take from the Cbct. We can check the cortical bone as well as the bone inside, because that marrow space, we should know what type of bone is there, how much primary stability we are going to get from that one. Initially, we were talking about the primary stability we are getting from the cortical part. So considering all these things, we have to make a plan. And in the number one, first place, we should have a plan for the prosthetic part. Then we have to come back to the surgery. So if we have that plan, then only we can go for the immediate loading if it's a full mouth case. If it's otherwise, if it's a single tooth implant, people always get confused. Immediate implant, non-functional loading, immediate implant, functional loading. These three are three different things totally. So we are not talking about immediate implant placement and healing abutment. That means single stage surgery. That's a different thing. Immediate functional loading or non-functional loading. So if it is immediate functional loading, it should be splintered implant. It should have that number of primary stability, should have that kind of bone, should have that long type of implant. And then only we can go with that. 2 years ago, one of my friend from India, he sent one OPG, was asking, can I do this immediate, all on 4? So that's a different thing. We have to learn how to do all on 4. It's not like placing 4 implants. So I said, you have to learn that part, then you can do in this case. Unfortunately, this gentleman did the case, and after that he sent the case. So that was absolutely, unfortunately, wrong plan. So when we are going with one science, we have to follow whatever is there in that. So I have a case, immediate loading in Biocone. Biocone immediate loading is not possible. But there is a method to do immediate loading in Biocone. So when you are going with the Biocone science, you have to take that science. When you are going with the other science, you have to, when it is all on 4, immediate loading. So that each things we have to learn properly, then we can decide. And we can use Cbct, we can use literature and the textbook. That's the most important thing. But the textbooks, unfortunately, are outdated, not updated. Because by the time I write and finish one textbook, by the time it's going for proofreading, it's gone. The science is new now. But literature is not that way. Literature, if you always have an habit of going to Google Scholar, lot of literature, research papers are there. You cannot go wrong if you are sticking on to that habit. Just type immediate loading, type all on 4, type all on 6, and you are there.
Perfect. That was an amazing explanation, Doctor. Okay, now we come up with the last question by Dr. Kamal. That is, can short implants be used for sinus lifting along with bone graft and densa burrs and piezo equipment? Is it stable in sinus lifting cases?
Here, this is mixing up of everything. So when you are going to Biocone, there is no sinus lifting. It's called floor transportation, sinus floor transportation. It is not the way we do in other cases. It's not the way we do with the Sharjah. So if you are doing Biocone for the sinus lift, you can do it. It is little noisy, little tapping you need. Patient should be that strong. And once if you do that, you're actually tapping and breaking the sinus floor and pushing the entire bone. That's a floor transportation. Then you have to attach that sinus lift abutment into that one. Otherwise, the entire thing will go to the sinus. So that's a different method. But if the question is interesting, because if you have all these things, piezo, and again, you don't need piezo with the Sharjah. These two are two different things. So if you have Sharjah, you can lift the sinus. So you don't have to go for the short implant. You can use the long implant itself. I think I answered this.
Yes, you did. Brilliantly. Okay, so this comes to the end of all the Q&A sessions, and I hope all participants are happy with the answers by the best. Okay, so I think this is what brings us to the end of the webinar, and I would request all the participants to be a Prime member with us to, unveil all these important benefits of being a part of Dentist Channel Online family. And the link is in the chat section. So you can just go and right away click on the link and get the membership with the minimal charges, and the membership is available for the whole year. Okay, so thank you so much, Dr. Shoukath Ali, for
Thank you for giving this opportunity.
It was pleasant to meet you and to hear you actually, and to know about what is exactly going on around with implantology. And thank you so much again, and thank you so much, participants.
Thank you.
So we hope to see you again very soon, Doctor.
Thank you.
All right.
Have a nice day. Bye.